Now I'm going to talk about trauma-informed care, and many of these things have been said before, so I'm going to skip over a lot of them. This movement, from my point of view, from my understanding, originated about only 15 years ago due to coercive treatment of adults in inpatient units in the United States and kiddies who are being locked up in schools and dying when people sat on them under restraint. We know what it aims to educate about, and we know that mental health systems are often insensitive towards patients who've been traumatised. These are the US principles. I'll skip quickly through these. Patients should be valued. People should ask about abuse. We should use neutral language. We should never shame. We need to individualise treatment plans. We need to look at triggers, warning signs. Institutions need to be aware of this. Now, I want to add the affective interchange part to this. And this is designed to look at pointy-end, acute, one-off people in inpatient units, community settings, other places like that. If we think about deep unconscious traumatic memories in the right hemisphere that are not cognitive, we can recognise that some distressed, not all, some distressed patients may be unconscious traumatic memories. They are essentially then in the past. We shouldn't sit in front of them. I swore I wasn't going to say this, but when I started working 20 years ago, I used to smoke sitting next to my patients. And it had a lot of benefits because I didn't have to focus on their problems or their symptoms, but I could just be with them and we sat facing the same direction. I don't do that anymore. But that was in 1989. But I don't think you should sit in front of a patient. Sometimes I do seclusion reviews in the prison and I often sit below the prisoner. We need to listen and listen and listen. We've heard that over and over again. But we don't need to talk. You need to have time and you need to have space, and we don't often have space. We actually have a very good prison unit at home that has enormous amounts of space, and I'm sure it decreases the amount of medication we use enormously. It has 3 or 4 de-escalation units. One of them is as big as a cricket pitch. And it has 2 or 3 rooms, often including a television room. I think that's very helpful. When responding, we should use few words and a gentle voice. We shouldn't try to reassure people about things that they can't be reassured about, and we shouldn't question them. We should understand that the presence of a clinician alone may help a patient regulate their emotion with you. Now, I'm not naive. Patients still take ice. They still come into the emergency department with weapons. They still come in threatening. Those patients still need seclusion. They still need medication. But lots of patients can be seen in other ways. Trying to reflect how painful things might be will often be helpful. Questioning isn't good. Part of conversation, we talked about exchanges. Eye-to-eye contact's much harder, and that's whole degrees or PhDs in when to make eye-to-eye contact. But all the other components of the part of conversation can be very helpful. And if you have something engendered in you, a feeling that's very strong, you should take it away and talk to somebody else about it and try and hold it. This goes back to one of the first slides yesterday about what psychiatrists can do with placebo and what other psychiatrists can do with medication. We can use the person of the clinician to treat. Someone spoke yesterday about giving the medication and walking out of the room and waiting for it to work. We can use the person of the clinician as the active treatment agent. We should be proactively engaging people. We can contain and co-regulate. Sometimes the person struggling doesn't have the apparatus to do it themselves, so we can't tell them to do it or punish them for not being able to do it. And I think protected therapeutic time is really, really important. There's a good reason that we have more and more pet therapy, because they're very good therapists. We actually know that people who have pets live longer, have lower blood pressure, have less medical problems. Very brief vignette before I go on to make a few comments. David's been a public mental health patient of mine for 30 years. In his early life, he was often involved with drugs, incarcerated, locked up. He was diagnosed with depression, personality disorder. He often came in later years seeking safety. He thought he was going to hurt himself. He'd become agitated during this process, and he was often involved in takedowns and was given involuntary medication. He'd been abandoned by his mum to an orphanage when he was 4, and when he got a little bit older, he was given medication in that orphanage and sexually abused. The medication offered to him when he was given voluntary medication sometimes was often exactly the same medication he was given when he was drugged and abused. When he was seen as having complex post-traumatic stress disorder, all I did was tell everyone in the hospital his story and told them to give him some space, and he never had any more takedowns. He couldn't tolerate expressive therapy, regular therapy, to look at what had happened, but in a trauma-informed case management model, he's done extremely well, hasn't been admitted for 5 years. Susie's voices, Eric's fear of ridicule, David's takedowns, are all examples of deep-seated traumatic memories or the system's response to them. They all went undetected for many, many, many years. They all controlled their behaviour and others' responses to them. When you add the trauma lens to the DSM lens, things are much better. I think we do a lot of things well, again, in public mental health services. We mainstream, we destigmatise, we make things legitimate. We use some documents well, like an ISP used well can bring in a lot of features other than symptoms. We nurse and provide care with much warmth very well and very frequently. Obviously, we involve consumers and carers more and more and more. They were not visible on my horizon 20 years ago. We use contemporary treatments much better. Second generation antipsychotics and antidepressants are fabulous in comparison to what we did as a resident 20 years ago. Most of my appointments were trying to treat one side effect with another pill. We're much more transparent and accountable now. We shouldn't always put someone in the psych cubicle, though, I don't think. I don't think we should use a lot of staff for brief periods and ask repeated questions over and over again, instead of taking one comprehensive history and do it in a therapeutic manner. I don't think we should favour cross-section over longitudinal interviews, and we often get cross-sectional interviews. I don't think we should medicalise if it removes symptoms from context. We use takedowns too frequently, I think. I think most people here will know what I mean by a fishbowl. It's any piece of glass that separates anyone from anyone else. They work both ways. You can have a patient behind one, or you can have a nursing staff behind them. In our inpatient unit in Hobart, we've just taken out the piece of glass that separates the patients from the nursing station. One of my pet hates is having subjecting a patient to 6 people in a ward round. I think that's an interrogation, and not providing enough therapeutic time. I might skip over this study. This is basically a study that just shows that when you look at what's good with senior nurses who practice with psychotic patients, basically the recommendations are the same as those that we give for people who are needing trauma-related responses. For there to be more focus on trauma, I think we need to somehow send this message up to higher levels and have people appreciate the importance of this. We need to train, we need to have different ward shapes, and we need to have more time. I'm not going to talk much about most of this. There's a lot of stuff on the left-hand side, which is primary prevention, which we probably can't have much influence over, but where the most important things should happen. We're always stuck in the federal versus state funding dichotomy, which is always a problem. I'm going to talk mainly about what I think we should do at the coalface. But to change my service, we need money that goes to my CEO. If it doesn't go to my CEO, he can't do anything. We might have a national body that drives change and tools and policies and things, but if there isn't money that comes to my CEO to treat people in my service, they're not going to change. On the coalface, much like the seclusion and restraint initiatives, we need champions everywhere. I think wards need to be a lot of wards. Some are probably brilliant, and there's some very good wards being built in Queensland at the moment, but they need to be reshaped and redesigned to be more human, more welcoming, to have less divisions, to have less patriarchal divisions. And I think lots of those things can be done very simply. a woman in Queensland called Wendy Hoey went around and just with a sledgehammer and took the seclusion room door off. I'm going to mention the word protected therapeutic time probably about 10 times because I don't think there's enough time for people to talk and listen to people. And I think it needs to become a policy. I don't really know how this works, but I've just discovered 3 years ago in England they did make protected therapeutic time a mandatory policy so that every inpatient got 15 minutes with a nurse or other professional on every shift, and that would be an advance in many places, I think. We need to train a lot, and we need to think about employing people to be therapeutic in their statement of duties. Very often nursing staff do a great job, very busy with handover, ward rounds, paperwork, medication administration, which leaves very little time to talk to the patient in front of you, which is what I think we're sort of there for. 2 quick slides and then I think I've finished. We know that the Americans are doing some work here. This is a study in South Carolina that looked at a lot of clinicians in outpatient facilities and looked at the effect of trauma training. Very few of them had trauma training. 6 hours I wouldn't consider very much, although it might be helpful. Despite that, almost everybody who completed the questionnaire felt that they were comfortable, very comfortable or comfortable treating patients who might have trauma-related conditions. However, they couldn't pick the patients. But there was a strong relationship noted between the hours of training and the perception of trauma-related difficulty that had nothing to do with education or experience. It was just the trauma training they'd had. There's a lot of positive sentiment circulating around in this conference, and that's fabulous. I'm not sure how many of my colleagues are here. The biological paradigm is heavily entrenched. Louise was talking about juvenile bipolar disorder. 3-year-olds in America are given lithium. I think I said this yesterday. I think if this is going to change, we're going to need 20 or 30 years of dedicated effort. Political cycles are short. We talk about not labelling, but case mix and funding is related to diagnosis. It's very complicated. At home, people sort of know a little bit about how I think. I sat on a committee that was looking at a new document for a model of care for adult community mental health services. The only paradigm that was allowed in was assertive case management. I talked about trauma-informed care principles. There were 10 people in the room, 5 of them cried me down and 4 of them abstained. Joe Tucci is the president of the Australian Childhood Foundation. He did a study in 2006. And he said in the study that child abuse was perceived as less concerning to the public than the rising cost of petrol and problems associated with transport and roads. 31% of respondents stated that they would not believe children's stories about abuse, and 43% of respondents felt so poorly informed on the issue that they were unable to guess the number of reported cases, while those prepared to guess significantly underestimated the problem. Much is known about trauma, but I don't think this knowledge is particularly well disseminated. Application of this knowledge will be enormously beneficial. There'll be significant resistance, however. The tide may be turning, and the number of people here and interest in the positivity here, if that's a word, which I don't think it is phenomenal. Thank you.